Thank you very much for the introduction, and thank you so much for inviting me to this meeting. It's really a great honor to speak in front of all our nursing colleagues here. I'm probably the only non-nursing colleague in the crowd today, but I'm learning quite a bit. So, and of course, as a pharmacist, I also learn a lot from my nurses on a day-to-day basis. So this is something that I really cherish as an experience. So what I'm going to talk to you about today is something that I think many of us have dealt with over the last, if you've been involved with the care of lung cancer patients, I'm sure you've managed targeted therapy-related toxicities. So I'm going to share what we know in the literature. I'm going to share a little bit about what we know. And I think later on when we have the panel discussions, I think a lot of the things that we talked about within the next 20 minutes or so will consolidate. This is my disclosure. This is my talk for today. I'm going to start with some background, and then we'll talk about how to assess toxicities associated with targeted therapies. We'll talk about how to manage the side effects. And then as a pharmacist, we're like drug people, right? So we talked a little bit about the pharmacological management. I'm going to focus more on the drugs, toxicity-wise about the targeted therapy drugs, as well as how to use certain agents to manage the side effects of these targeted therapy agents. So that will be my last teaching point for today. Now, I'm going to start out with a case, and I think I'm going to use a case, someone that I've actually managed in practice. This is Mr. Lee. Let's meet him. He's a 67-year-old Chinese male who is newly diagnosed with non-small cell lung cancer. Through bronchoscopy and tissue biopsy, we actually did quite a few things for him, and then we were trying to find out his EGFR mutation status, looking at his ALK rearrangement status. We're looking at BRAF as well. These are basic labs that we're performing on the majority of our lung cancer patients nowadays. After all that, I'm not going to go through all the diagnostics on what happened, but essentially our oncologist started this patient on erlotinib. So 4 weeks later, he came back to the pharmacy, and I saw him, and he was so happy to see me. This uncle, right, he was jumping in joy. Hey, I'm rejuvenated as a teenager again. I'm like, what do you mean? And he was like, oh, I got all these rashes all over my face, my chest. I'm like having acne like my teenage grandson. And I was like, huh? But what he complained about is that a lot of these side effects are very intolerable. So not just the rashes, but also a lot of itchiness that he's experiencing as well. Now let's go through a little bit about these targeted therapy agents, because our focus for today is talking about these agents, and of course the associated toxicities. So we already know from guidelines that if you have patients who are EGFR mutation positive, there are multiple agents that are available. These are the first and second generation EGFR inhibitors. So we have things like gefitinib, which we use quite greatly in the Asia-Pacific region. We have erlotinib, which is what I just talked about. And then we have afatinib, which we consider as a second generation, quote unquote. But these are now being regarded as first-line therapy. And we routinely use them in Singapore as well, and in many parts of the country in the Asia-Pacific region. And of course, even if these patients, if they progress, and after they go through certain type of mutation testing, these patients can still receive these therapies, or they receive a third generation TKI, osimertinib, which we're starting using a lot in our patients as well in Singapore. Besides the EGFR mutation status, we also look into the ALK rearrangement status, because we now do have targeted therapy agents that specifically targeting patients who have rearrangement positive of ALK. So a lot of these agents that we have, crizotinib, ceritinib, alectinib, a lot of these agents that are made available as well. And then let's not forget about patients who may have BRAF mutation positivity. So we have some of these drugs originally designed for usage in treatment of melanoma. Now we can also use these for lung cancer. So dabrafenib as well as trametinib, these agents are also indicated for very small percentages of patients who actually have BRAF mutation positivity. So all these leading to the slide, because I wanted to talk about what are these targeted therapy agents that are available and what are the associated toxicities with these drugs. Now, you think it's a walk in the park with these targeted therapy agents? Not really true. I actually have cited the incidence of these drugs in terms of toxicity from a lot of the studies that were done in Asia, and again, mainly because coming from my kind of background here. But I wanted to highlight what are the incidence of many of these side effects. So obviously, rash is something that we commonly see, especially with afatinib, which really affects a lot of our patients. GI side effects as well, diarrhea that we see a lot of our patients as well. Many of our patients also experience nail side effects like paronychia or so. And even some of these agents that we use for, as BRAF positivity, you could see that rash as well as pruritus. These are also common side effects that we encounter in our patients. The ALK rearrangement inhibitors drugs that we have, like crizotinib or so, these are not a walk in the park as well. There are quite a number of side effects. Vision disorders are something that we do note in patients who are on crizotinib. Alectinib are related to some of the GI side effects like nausea, vomiting, diarrhea. And there are some serious adverse events listed in many of the package insert or even some of the experience among our patients who are receiving these agents. Now, what are the mechanism behind some of these side effects? I do wanted to pay attention to some of the dermatological side effects, especially what Mr. Lee is experiencing. So we kind of know a lot about this in the literature, but what exactly is happening on the biomedical, in terms of molecular sort of level? So we know that the epidermal growth factor receptors actually are found all over our skin, in the epidermis layer of our skin. And what happens is that when you have disruption of these receptors by binding the drugs to inhibit the action of the EGFRs, what happens is that it calls on a lot of the inflammatory markers. And these are things like chemokines, neutrophils, lymphocytes, so that start attacking the integrity of the epidermis layer of the skin, causing a lot of disruption as well as some of the redness and tenderness that we see in the clinical observations. So this kind of summarized very well by Mario. It was a very old article that was published, but pretty much kind of summarized what exactly are the mechanisms of actions, why this is happening with EGFR inhibition that causes some of the dermatological side effects. So again, based on not just inflammatory pathways, but also because of abnormal maturation and differentiation of some of the skin layers or so that causes some of the side effects that we see, such as dry skin as well as some of the itchiness or so. So I think the bottom line is we really need to make sure that we counsel our patients well. We talk to our patients about these side effects and anticipate the fact that when you're on these TKIs, these side effects do happen. So this is my lovely Lego minifigure. Everyone has their own way to counsel their patients about these side effects or so, and we just have to think of a creative way to make patients remember some of these things. So what are some of the common things that we do see? Again, the rashes, eyelashes abnormalities, dry skin, pruritus, itchiness, nail alterations, or even hair loss as well. We've done some studies when some of these TKIs were being heavily used in our cancer center, and we published some of these results in supportive care. What we are trying to figure out is the trajectory of when these side effects occur and how severe they can get. So in this particular study, what we have done was we're looking into each of the individual toxicity, and then we're looking into what is the onset of some of these toxicities at different time frames. So what we have observed, obviously, is the rash and some of the itchiness so happen very, very early on when somebody started on these TKIs. Within a week or two, I bet many of you get phone calls from your patients already that they're experiencing some of these side effects. But towards about a month or so into their treatment, you're starting seeing other types of side effects, such as dryness and the nail toxicity, as well as some of the hair side effects as well. These are some pictures of some of the patients that I have personally managed. So you could see that a lot of these patients are experiencing these pustular sort of rash. Again, many times that we think they look like acne, but they're all over the trunk as well as at the back of these patients as well. So depending on, again, the extensiveness of these rashes, it could bother the patients a lot with these symptoms. So you can see that dryness of the skin is very, very common among our patients. So many of these patients, in fact, have more than 30% of the body surface area affected by the dry skin. And that's evident here. You can see that different sort of patterns that we are observing in our patients. Nail toxicity is one that I personally feel that is very hard to manage. Together with our nurses and sometimes our oncologists, we're trying to figure out a plan on how to counsel our patients to manage these nail toxicities. And mainly because a lot of times, they become very pustular, and in fact, they're bleeding, it's hemorrhage. So we got to figure out what is the best plan to counsel our patients. In a very hot, country like Singapore, how do you ensure that our patients can be well protected and not getting infected from some of these nail side effects or so that they're experiencing? Those are challenges that we're facing in our clinical practice. So assessing the side effect is a key because I think as allied health professions or even nurses, one of the major roles that we play is to make sure that when we look at our patients, we evaluate them and we're able to clinically assess them accurately to ensure that we report the toxicities in the most accurate fashion. So again, we wanted to ensure that in order to assess these right so that we're able to pair up with the most appropriate recommendation on how to manage these toxicities. And this is important because if you look at package insert or so, it talks about like, okay, so if somebody experiencing severe skin side effects, you may potentially need to dose reduce the TKIs in future cycles. So how do you ensure that you're getting that accurate, so to speak, description, and then you are able to not affect the patient's treatment outcomes by dose reducing in an appropriate manner? So which is why we thought about, okay, so what tools should we be using to assess these dermatological side effects associated with targeted therapies? Now, the most common one that's being used in practice nowadays is CTCAE for looking into a lot of these toxicities. Again, it's heavily adopted in clinical trials. We still use them nowadays, but there is also another tool that's specifically developed by the MASCC, Multinational Association Supportive Care in Cancer, that look into skin toxicities with TKIs. This is a tool that's specifically designed to capture some of the toxicities, dermatological toxicities I'm talking about, that's associated with the tyrosine kinase inhibitors. So we also did some studies to try to look at how well does the MAST tool actually capture as well as correlate with some of the symptoms that you see under the CTCAE tool, because our clinicians were very afraid to use MAST, M-E-S-T-T, unless we know that it correlates well with CTCAE. And it turns out that it actually correlates quite well in many of the domains, ranging from rash or even to some of the nail changes or so. The correlation is actually moderate to high and is statistically significant. But what I want to show you is that the reason why we think that using a more specific tool like MAST is better is because if you look at the wording of some of these toxicities, they're much more specific related to tyrosine kinase inhibitors, associated toxicities. And of course, it's more descriptive as well, like how many of the pustules that we observe in our patients, what are the number of areas that are involved, whether or not they affect, so to speak, certain types of emotional functioning, et cetera. So a lot more specific comparing to CTCAE. Now, GI side effect, unfortunately, we don't really have a specific tool designed for TKI, but generally our clinicians love using CTCAE as a tool to describe. The way I remember is that if somebody has exceeded 6 stools movement per day, right, I think that's already a bad sign. That's already qualifying somebody to up to like grade 3 sort of toxicity. You need a lot more aggressive sort of management. But again, depending on, again, how severe that's affecting your patients, you need some sort of objective way to quantify this, and this is why we are having this particular tool. So how do we manage? I think that's the bottom line of these side effects. Now, coming back to Mr. Lee, he actually is quite bothered by the rashes that he's experiencing and also some dryness that he's having on his skin as well. So obviously, these are some of the very typical side effects that our patients on TKI are experiencing. The question is, how should we manage these rashes, pruritus, and dry skin? Well, on routine basis, our nurses at the cancer center actually counsel our patients on the following. So on initiation, first of all, make sure that they are already aggressively using moisturizers at least twice a day. In a sunny country like Singapore, you definitely need to ensure that there's minimal exposure to sunlight, using some kind of sunblock to ensure that they are not getting any severe photosensitivity or so. This is something that we routinely recommend. Try to shower with bath oil or shower oil, again, for better trapping of moistures. If patients starting to develop rashes, these are things that we recommend. Like, for instance, for women or so, we still encourage them to use makeup. As long as it's water-based, it's fine. Itchiness, you can use cold compress that will help to minimize some of that. For affected toenails, avoid frictions as pressure. We actually recommend our patients using closed shoes, but I know that that's very controversial out there. But again, the whole point is we wanted to ensure that patients do report the following. So if they have any pain or discomfort, if they see any purulent or pus discharge or so, or suspicion for any sort of infections, that's overt redness or so that they see with certain parts of the body, they really should come back to us and report to us about the toxicity so that they can actively be managed. And these are questions that as allied health professionals, even as nurses, we should be asking our patients. So if they're really experiencing these side effects, where's the location, what's the color, how does it look like, is it painful, is my skin broken or cracked, and is there any drainage? I think these are typical things that we should be assessing in majority of our patients who are on these TKIs. So there are management guidelines, and I think later on my colleagues will talk a little bit more about how they manage in their parts of the world. Beth and I were serving on the MAST skin toxicity guidelines. We came up with the EGFR inhibitor associated derm toxicity guidelines that was published quite a number of years ago. Over the years or so, there are also many guidelines being developed. My lung cancer doctors decided to get together within the country of Singapore and came up with a management guideline published very recently in the Asia Pacific JCO, looking into how to manage the TKI-associated cutaneous and GI toxicity. I think that's sponsored by pharma. Let's not go into that. So anyway, The things that we talked about in the guidelines are the following. So we talk about rash. How do you manage in terms of preventive and treatment? There are some weak data out there to talk about maybe we can use hydrocortisone also as prevention, or even using minocycline. There's some small-scale studies out there. We do worry about the photosensitivity associated with these tetracycline type of agents. Again, minocycline is less photosensitizing, but a lot of our doctors like using doxycycline, so that's something that we need to worry about. But for treating also, you may want to think about using some of these steroid creams or so, because that actually will help to minimize some of the side effects. If we have patients who actually have grade 2 and above rashes or so, our team actually will start our patients on some of the antibiotics, like doxycycline or minocycline on these patients. Some of our patients also getting clindamycin topical, except the only clindamycin topical that we have is a gel, which I actually don't prefer because gel actually dries up the skin a lot, especially with these EGFR-related toxicity. When the skin is very, very dry and we're putting more gel on it, it's actually not the best combination. So I try to avoid that. Pruritus is something that we do worry about as well because it's very symptomatic and it bothers patients a lot. Most of the things you can see are the use of antihistamines. The only caveat, of course, you have to worry about is that many of the antihistamines potentially can be sedating. So we try to use something sedating at night so that people can sleep through, like hydroxyzine or so. During the day, we'll use something that's long-acting, like once a day loratadine or Zyrtec, something that patients can tolerate. The bottom line is we don't want to get these patients too sedated because lung cancer patients tend to be old. You don't want to put them on long-term antihistamine that will make them drowsy or sedated. Cirrhosis, dry skin or so, I think it has to go with bathing oils, moisturizers. After we started having TKIs, we have a whole section of pharmacy that's selling different types of cream. Again, heavy types of cream, making sure that our patients know how to use them. Emollients or so, these are great. We use a lot of urea creams at our pharmacy as well for scaly sort of areas. These are really good drugs that are good to protect the skin for trapping the moist on the skin itself. And then paronychia, this is a very tricky one. We don't really have very good drugs. I think we need actually a lot of TLC for this because patients really get bothered by paronychia. But we do try to use topical antibiotics if the nail itself looks like it's infective. And that's something that we do worry a lot about because sometimes we see pus coming out. So you actually need active management of these if we actually observe them right after they started with these treatment. And fissures, wear protective footwear and avoid friction with fingertips, toes, etc. These are ways that we're trying to prevent further exacerbation of the fissures that our patients are experiencing. GI side effects are probably more prominent related to afatinib or so. We never really encountered a lot of these when we were just using gefitinib and erlotinib until we have some of these later generations TKIs. We are seeing a lot more diarrhea. So in fact, we actively start patients on some of these anti-diarrheal drugs on these patients who are on afatinib, just prophylaxis or so, because a lot of these patients are really experiencing them when they started these drugs. We monitor them very closely for whether or not that they have grade 1 or 2 or even above toxicities. If it's grade 1 or 2, meaning that's less than 6 bowel movements per day, you pretty much can make sure that your patients take anti-diarrheal at home until they're self-managed very well. Most of the time, what I educate our patients is that they can continue on and take loperamide or Imodium, one of these agents, continually until their diarrhea stops for at least 12 hours. It's kind of similar to how we manage irinotecan-related diarrhea. But the bottom line is you want to use these drugs to control the peristalsis so that they don't get these diarrheas. And of course, oral rehydration salt, don't forget about that. I think it's very crucial to remind our patients that they need to be on these solutions so that they get enough ions or so electrolytes while they are getting these diarrhea episodes. If they have experienced, which we have quite a few of these, very severe diarrhea in the beginning while they started on these TKIs, they really need to be admitted to the hospital for intravenous drips and all that kind of stuff, management in the inpatient setting. What I'm going to do is I'll talk a little bit about pharmacological management, and I think many of you should know a lot about these, but I'll go into specific details about these drugs. So these are all our wonderful TKIs that are EGFR inhibitors, ranging from first to third generations. Doses are listed for you here. Some teaching points for many of you, a lot of the drugs that affect the gastric sort of pH, for example, like proton pump inhibitors, H2 blockers, we're talking about like N-acids or so. These can affect the absorption of these drugs, so you should try to minimize, so to speak, the use of these PPIs or so with these agents. So food also has an effect, so I think this is important for counseling, and drug-drug interactions. As a pharmacist, I can never forget about these because many of these drugs are associated with CYP3A4 metabolism pathways, so you need to avoid using drugs that might be inhibiting or inducing these drugs, otherwise that may affect the drug levels or even increasing the risk of toxicities. These are ALK inhibitors. The side effect profiles are relatively manageable, but again, some of these have very specific food effects also, and many of these also have drug interactions related to CYP3A4. So again, something that we need to be very cautious about. Drugs that actually to manage the toxicities of these tyrosine kinase inhibitors, we use a lot of steroids, right? Topical steroids. Now, one thing that I always teach my nurse practitioners and APNs is that how much to prescribe, because a lot of times our patients are not getting enough creams, not getting enough ointments. So the truth is you have to figure out how much cream that your patients really require. And again, if you're thinking about his face or perhaps like, just one arm, the amount that you need is actually very little. So the way how we quantify is based on how much of the topical that you need for the fingertip for application. So for a face or so, 2.5 applications is probably more than sufficient. Obviously, for the trunk, you need a lot more, right? So you need about 7 applications here of a fingertip. The reason why this is important is because it helps you to figure out how much that you need to prescribe for your patient. So you may need like more than 15 grams of a tube for your patient or so. So if you need it for a whole trunk, you probably need a lot more, isn't it? And the reason why you need this is because you don't want your patients keep coming back for refills when they actually can get a much larger quantity. The caveat here is, of course, depending on which particular lotion, cream, or ointments that you're talking about, again, different potencies or so, different dosage forms are available. So the vehicle matters is also an important point. Not all of them comes in ointments or cream. I think these are basic things. We know that women or so, they tend to prefer ointments and lotions. Men certainly hate it. I already told you already, gels we don't really like because they dry up the skin even more, so it's not something that we prefer. But we do worry about some of the side effects. For instance, skin atrophy is a problem, so we try not to use medium or even high potency steroids in our patients on the face, because that potentially could be a problem if you use it for a long term. And of course, we worry about again, long-term usage that may lead to infections or so. Again, a lot of education needed related topical steroids usage in our patients. Antimicrobials, so I'm just limiting to the ones that we commonly would see that we use in our patients on TKI. So tetracyclines, clindamycin, both of these are bacteriostatic drugs. The side effect profile are relatively okay to manage, but we do worry about long-term usage because with minocycline, doxycycline, we already talked about photosensitivity. We also worry about the interactions. If your patients are on these drugs, you cannot drink milk together with doxycycline because your doxycycline would not be effective. Space it out, okay? Calcium tablets you cannot take with your doxycycline because it will be binded by the doxycycline or any of these antibiotics. It will be ineffective. So these are, again, important counseling points that we need to continue to educate our patients. Clindamycin, long-term usage, you already know that may associate with C. difficile, diarrhea or so. So again, those are things that we need to be conscious about. Again, I already talked a little bit more about antihistamines earlier. We do worry about the sedation that related to first-generation antihistamines, so try to use second-generation during the day. But for nighttime usage, you can use a lower dose in your elderly to help them to go to sleep, because if it's very itchy, so your patients can be quite affected by these pruritus events. And then lastly, antidiarrheal. So we already know that there are a lot of these products out there on the market. Just be very conscious about how much you use in your patients. And again, if your patients are not able to manage as outpatient, they really need to be admitted to the inpatient setting, especially in the beginning while they're starting on these TKIs. But generally, I think diarrhea can be quite well managed at home with antidiarrheals. Again, don't forget about oral rehydration salts. So in the Asian part of the world, we use a lot of ionizing solutions, things like Pocari. I'm sure the Japanese know what these drinks are, or Gatorade in our more westernized sort of settings. These are great fluid, in terms of replacements with electrolytes or so, but generally they're too sweet. So what happens is that with these high glucose amount in these drinks, what happens is that you will trigger osmosis or osmotic diarrhea, and that's not recommended. So if you want to use any of these Pocari, Gatorade, these solutions for replacing fluids and electrolytes, do one-to-one sort of solution so that you dilute it out. It's much easier. It may not taste as good, but generally it's something a lot better for replacing the fluids and electrolytes in your patients. This is from the guidelines. The last piece of information that I really want to present to you is that we really need multidisciplinary effort to manage these toxicities associated with the targeted therapies. Not just our medical oncologists or radiation oncologists, nurses, but pharmacists. Many of us should be involved in the care of these patients because TKI-associated toxicities are really getting a lot more complicated nowadays. So these are my take-home messages. Again, we use a lot of these drugs for managing our lung cancer patients, but they're associated with dermatological and GI side effects. Timely management is a key. Knowing the trajectory, when do these side effects onset and the severity is important. And then again, this requires a multidisciplinary approach in terms of the management. Very, very last slide. I am a board of director for MASS, and I love this association. Beth has also been to MASS many times. MASS is happening in Vienna next year. We have a skin toxicity group within MASS. It's a great group if you really want to learn more about dermatological side effects associated with these TKIs or so. We have study group meetings, and then we invite abstracts or so. We even have sessions that talk about it. Some great experts in the crowd with MASS skin toxicity group. If you haven't heard about it, please approach me. You can, or Beth or so, you can find out more. Thank you so much for having me. Thank you again.